For our final presentation, we are joined by Dr. Anna DePompolo. Dr. DePompolo, who's also known as DePomps, is a pediatric emergency medicine physician at Children's Minnesota. Dr. DePomps is passionate about providing care to critically sick and injured children. She is actively engaged in activities that provide care to children in the pre-hospital setting through EMS and disaster preparedness medicine. She's been the Minnesota EMSC Medical Director since 2021. She's passionate about providing education and resources to those stabilizing, caring, and transferring the critically injured or sick child. Her presentation, Tiny Lives, Big Decisions, Navigating Pediatric Mass Casualty Triage, will cover these objectives. I will turn things over to you, Dr. DePompolo.
Thank you. All right, let's see if I can get this to work. Can you guys see the slides?
We can.
Okay, excellent. It's always a good thing to start off here. So thank you for having me here tonight. We've had some excellent speakers, and I'm hopeful that we'll wrap up the night with another talk here and get you guys on with your evening. So thank you for staying through the talks here. See if I can advance my slides here. Here we go. I have no disclosures. As was kind of alluded, so the big things for our talk today is I want to kind of set the stage for how to triage pediatric patients during a mass casualty incident, kind of why this matters, why it's important to understand pediatric specifics, kind of evaluate some of the algorithms in primary triage in the field, and then apply that to some of our scenarios. So spoiler alert, there'll be a little audience participation requested. And through this, we'll kind of interject some anatomic, physiologic, and developmental pieces on pediatric patients, which have sort of been alluded on the first talk for the day by Dr. Wilnitz, but we'll kind of go through a couple other things to be thinking about. So the why. So a quarter of the population are children, so it's expected that during any mass casualty incident that pediatric patients will be required for care. And depending on the scenario, if it's a school shooting or a bus crash, that might be even a higher percentage of the population you're needing to serve during that incident. And we do know, as kind of some of our speakers have alluded to today, that there are some unique healthcare needs when caring for pediatric patients. And we're going to talk a little bit more about some of those physiologic as well as developmental aspects that make caring for pediatric patients different than adult patients. And then we unfortunately live in a world where we're just seeing increasing frequency of these disasters, both man-made and natural. So, anytime you're approaching a scenario, you all know very well, being in first responders, that scene safety and evaluating the scenario in front of you is always of benefit. Is this an evolving situation where your safety may be of concern? Is there any need for decontamination? And making sure you don't become a victim yourself as you're trying to render aid. And then in a pediatric scenario, depending on where you're serving, especially if you're in a more critical access area, trying to size up the number of pediatric patients and making individuals aware of the resources and needs you're going to have. And in these scenarios, especially for the walking wounded, you might need to employ a bystander to help kind of monitor the less critically ill while you're rendering aid to those that need your services. So when it comes to these algorithms and how to go about, triaging during a mass casualty incident, there really isn't a gold standard, if you will, or like the Goldilocks of triaging. And really, these algorithms, they're all trying to help allocate resources to serve the greatest good. And, you want them to triage appropriately because you don't want to over triage or under triage. You really want resources to be going adequately to all of the needs. And you want it to be quick. You might even have to be doing some just-in-time training. And so it needs to be user-friendly as well. So when it comes to these algorithms, there's actually several different types used across the world, which I found interesting when I was kind of looking into the literature more. And so with this, there isn't really a general universal consensus of what is the best or most useful algorithm. They all have, benefits and positives and negatives. And unfortunately, when it comes to these triage algorithms, it's very difficult to study them, especially in a real-time scenario. And as we know with simulations, they do give us some information, but they're not quite the same as when you're dealing with an active situation. When we look at pediatric specific triage systems, there are a few algorithms that kind of are a little bit more of a nod to pediatric patients. Specifically in the United States, there's Jumpstart, which is kind of a offshoot of START triage, where it's looking at more assessing patients 8 years and under. But in the world, there's pediatric triage tape and CareFlight that have been used as well for pediatric patients. And the thing to note about all these algorithms is they're really kind of all using the same things. Can they walk? What are they breathing? Do they have a pulse? And what is their mentation? And the pediatric triage tape is sort of unique in the sense that it almost kind of tails off of a Broslow tape where you line it up against the pediatric patient and it provides, vital signs regarding that patient's respective age as it should be with that tape. But again, for the purposes of this talk, I'm going to really focus on what's more utilized in the United States and most likely what one of your services are probably using in a mass casualty situation, which is SALT or Jumpstart. And these both use kind of, again, the ability to walk as kind of the first triage point, and then use black, red, yellow, and green as the triage levels, with SALT also having kind of this gray or expectant category, depending on the resources you have available and how you might triage that patient or how much you might render aid at that time. And then both SALT and Jumpstart do allow for respiratory intervention in pediatric patients, which is unique and kind of considers the physiologic differences of pediatric patients compared to adults, as we kind of already heard in our earlier talks today, that the pediatric airways are definitely different and most arrests are respiratory. So looking at these algorithms a little closer before we kind of apply them to some scenarios, SALT starts with basically triaging based on movement and ability to walk or ambulate. And so if you're able to walk and follow commands and move to an area, you're going to be assessed third. If you can make a purposeful waving and clearly making some motion, they would be second. And those who are still or not moving at all are going to be assessed first. And SALT does allow for a few more interventions than Jumpstart would, including hemorrhage control. This allows for opening an airway in a child and giving 2 rescue breaths, giving chest compressions, and then if there's an antidote required, injecting that. And then from there, it's really assessing if they're breathing or not. If they don't breathe after opening a pediatric airway and giving rescue breaths, then they're considered black or deceased. If they do start breathing, but they're not making any purposeful movements, or don't have a pulse, or their respiratory distress, or their major hemorrhage isn't controlled, then they're either going to be considered red or, again, this expectant or black, depending on what your resources are. And if any of those are present, then depending on their injuries, would be considered either green or yellow. Jumpstart, again, it was kind of designed as a break off of START triage, with just adding some pediatric specific things, mostly the airway piece, and allowing for rescue breaths to be applied, and then trying to help with the mental status and kind of obey commands as depending on a patient's age. If this is an infant, their interactions from a mental status might be different than an adult. And so they do try to kind of have some additional triage expectations in there as you're trying to determine pediatric triage level. And again, all of these algorithms are really supposed to be very quick, right? You're trying to make a quick assessment. You're not trying to provide a ton of care. You're really just trying to figure out who needs to go first to get additional services. And again, they do really focus on this, breathing, perfusion, and mental status. So Jumpstart, when we're looking at how to walk through this one, initially it is, can they walk? If they can, they're triage green. If they can't walk, it's again based on their breathing. If they aren't breathing, you can position their airway. If they start breathing spontaneously, they're red. If they have a pulse, then you can give the 5 rescue breaths and then they're triage red. But if they don't have a palpable pulse, then they would be triage black or expectant. If they are breathing, then it goes to basically what is the respiratory rate. So they give a range of kind of 15 to 45, which is a very kind of generous but range to kind of determine. And so if they're within those parameters, then they can go on, and it depends on their mental status. And if they're um, altered or they're not responding appropriately or to pain, then they'd be triaged red. But if they are alert or verbalizing, or making purposeful movement away from pain, then they would be considered yellow or delayed. And if they are outside of those respiratory ranges, then they be triaged red. When we're thinking about these algorithms, it's somewhat helpful to understand some developmental considerations for these pediatric patients, such as when would a kid even potentially start walking? And if you've had your own kids, you probably have a generalized idea of this, but most children walk around 12 to 15 months of age. And so this could be helpful as you're coming up on scene. If they're, an 8-month-old or an infant, they're probably not going to walk. But if they're, older than that, then you would expect them to be able to walk. And children in stressful environments, they may not follow your commands, they may not respond. And so, knowing that piece as you're trying to direct their care, and that kids tend to be kind of a moth to a flame. So, they may actually move further into a dangerous area. And so, this would again require potentially a third party or somebody who can help try to maintain their safety as they're waiting for care. And children can't always ask for what they need during these scenarios. All right, now it's your time to participate. So we're going to do some scenarios and then a little potpourri of pediatric specific care. So this is, oh, I'm going to see, can I move this down for a second? So a tornado hits a daycare and you respond, and the first patient you come upon is an 8-month-old male. So again, probably wouldn't walk. So they're not able to walk, but they wouldn't at this age anyway. They find that they don't have any respiratory rate, but they do have a palpable pulse. And so you reposition their airway and they spontaneously start breathing, but they continue to be unresponsive and they appear limp and blue. So I'd love you guys to take a second. And I think if you just click on the screen, it should um, give me your triage level. And then I think Chelsea will reveal once we get a few of these. All right, awesome. So majority said red. There's a little bit of yellow, some black and green. So let's go through it. Okay, so we're going to start with jumpstart. So this patient can't walk. So right out of the way, they wouldn't necessarily be green. When it comes to if they're breathing, so they weren't initially breathing, but we positioned their airway and they had a palpable pulse. And so they would be uh, triage red either way, I guess, whichever one you want to go down that way. And then if we do salt, so they would be triage first because they're not moving. And so they are breathing. And so then it comes down to, are they obeying any commands? No. So then we'd move down here. And depending again, so this is where some of you indicated black, which depending on your resources might be the case. Otherwise, red would be potentially another option for triage. All right. So I won't belabor airways on pediatric patients much as there was a whole talk earlier today, but just to reiterate, pediatric airways are different than adults and obviously more likely to be different the younger the patient is. Remember, kids have big heads the smaller they are, and with their big heads, it pushes their heads forward. So they're more inclined to potentially obstruct their airway just even from the positioning of their body. And so this is where both, Jumpstart and SALT really allow an intervention here to see if this changes potentially the outcome for this patient. In addition, the pediatric patients do have, again, a lot of tissue in the back of their mouth, and there's large tongues. They have a big adenoids and tonsillar tissue, which could obstruct. And then their immune system, or their immune systems, their nervous systems are immature, which can sometimes lead to apnea, and their airways are smaller and can be more prone to obstruction. So this is the importance of why airway intervention is so important in these mass casualty algorithms. All right, your opportunity to try again here with another patient. So you moved on, you're 8-month-olds getting care. Now you come across a 4-year-old female. They're not able to walk. They are breathing about 8 breaths per minute. They have palpable pulses, but they are unresponsive, and you find them impaled on some shelving bracking. I'll give you, Chelsea will release the results here after we get enough response. Okay. All right. So a lot of red again, a couple for yellow, um, a couple for green, and then some for black. So again, let's go through. So we're going to start with Jumpstart again. So they're not able to walk, so they're not a green. They are breathing, and they do have a palpable pulse. And so then it goes to what is their work of breathing and their rate of breathing. So they're outside of this range of 15 to 45 according to Jumpstart. So they would be considered red according to the Jumpstart. When we look at SALT, again, they would be triage first because they're not walking. They are breathing, so then it goes really into, are they making any purposeful movements, which they are not. But they do have a pulse, and then we don't know a lot from this basic information if they're in distress or if they're bleeding out, but because they don't obey the commands, they would come down to again, this is where SALT is a little bit harder. So is your resources allowing for you to care for them where they would be red, or if not, then they would be black or expectant. So red. So in this case, when we're thinking about just body characteristics with pediatric patients compared to adults, they're compact and they're squishy would be, I guess, two adjectives. So you have a lot of organs in a small space. And so depending on the scenario, the same hit to an adult compared to a child may hurt more organs. In addition, their chest wall and their skeletal system isn't as developed. So they're, again, more compliant. Their chest walls are compliant. And so you might not see a lot of outward signs of trauma, yet internally they could have lung contusions or internal bleeding, but not a lot of indication that would show it on the outside. And again, with the structure of their body, their muscles aren't as well developed. They don't have as much subcutaneous tissue, so there's less padding to diffuse these forces that they might be sustaining. When we think about energy stores, children have lower glycogen storages compared to adults, so they're at risk for hypoglycemia. So this is obviously not part of our primary algorithms, but something if we're considering mass casualty care for pediatric patients to be considering. And they do have higher metabolic needs, so they're going to need fluid and food, but they may actually refuse it if they're under a lot of stress or don't have a caregiver that they know providing it. And so it's something that will need to be monitored. We're changing up the scenario. So now it's a school bus crash with an anhydrous ammonia tanker. So this is a 10-year-old male who's not able to walk. They're breathing about 30 breaths per minute. They do have pulses present. They're answering their questions, and they have fairly significant burns to their torso and legs. I feel like I need hold music for you guys. All right. So we have about almost like a 50-50 split. So some red, some yellow, and then a couple for black and green. Okay. So let's walk through them again. So again, we're going to start with jumpstart. So they're not walking, but this guy is breathing, has pulses, answering questions. So that gets us down pretty far on jumpstart, and the respiratory rate is normal. So then we can start and then getting into this area here where it's either going to be red or yellow, which is what we primarily thought. And this guy is answering questions, and so he's neurologically acting appropriate. So he would be considered yellow according to Jumpstart. When we look at salt, so he might be considered actually a second wave triage because he's going to be able to wave and purposefully interacting with you. He's breathing, he's obeying commands. As far as we know, he's not hemorrhaging out. He doesn't appear to be any respiratory distress and he's got pulses. So he's going to come over here, and this would really depend on, I guess, if we're saying he has fairly significant burns, then he's probably going to be a yellow. So yellow is what I would say. So again, some physiologic considerations with pediatric patients. So they have less circulating blood volume compared to adults. And we've kind of heard in a couple of the other talks, when it comes to pediatric patients, they can compensate pretty well until they can't compensate any longer. And some of the early warning signs could be some tachypnea and tachycardia. And the later signs are bradycardia and hypotension. And so really, the sooner we can intervene if we're seeing these vital sign discrepancies, especially the subtle ones, hopefully the better outcome for these pediatric patients. All right, we're moving on to the next patient. I think I have 6 patients total, so we're on 4. It's a 7-year-old female, not able to walk, breathing about 35 breaths per minute, does have strong pulses, is following commands, is coughing and complaining of shortness of breath, and has some tearing and watering of the eyes. All right. Okay, so some red, a lot yellow, a few green, and no black. All right, let's walk through it. Okay, so patient able to walk, no. So wouldn't be a green according to Jumpstart. They are breathing, and so then when we look at the rate of breathing of between the 15 and 45, they're within it. So then it goes to, do they have pulses? Yes. And then their mentation status, which this one is following commands, and so it would be considered a yellow. With salt, again, probably triaging second. They are breathing, they're obeying commands, they have a peripheral pulse, they're not in respiratory distress, and as far as we know, I mean, respiratory distress, I guess, could be, we don't know how distressed, but their vital signs would indicate they're fairly normal. So I would say they're probably either a green or yellow according to this. And so I think this would really kind of go depending on how short of breath or, you know, how much they're complaining of this difficulty breathing. So this one I think could go probably either way on that one. But ultimately I went with yellow based on the Jumpstart one. So when we're thinking of like toxic exposures for pediatric patients, um, again, we know their vital signs are different. They breathe faster and therefore their exposure is going to be increased compared to adults because they're ventilating, more times a minute. In addition, their body surface area is larger to their body mass, so they're going to have more absorption and their skin is more permeable. And then their proximity to the ground is lower, and a lot of these toxins tend to kind of fall closer to the ground. So they're at more risk for being exposed and possibly having more effects from whatever the toxic exposure could be. In addition, when we think about their body size, the younger, obviously, their temperature regulation sometimes requires more external support. And so this is an important thing to be monitoring. Again, not something you're doing on necessarily a primary triage, but when we're caring for these pediatric patients in a mass casualty environment. And if decontamination is required, always considering possibly, active rewarming blankets. If they're needing IV fluids, considering them to be warmed, and then radiant warmers. All right, so patient five, still in the school bus. It's a 12-year-old female. She is able to walk. She's breathing about 25 breaths per minute. She's got pulses. She's answering questions, and you find she has some minor cuts. Nice. Okay. So a lot for green, a smattering of red and yellow. All right. So can walk. So when we go with jumpstart, they're considered green. In salt, so they would be assessed third. So in this case, they are breathing. They don't seem to have any of these issues, such as trouble breathing, hemorrhaging, and they are mentating normally. And I would say with minor cuts, they have minimal injuries, so they would be green. So when we consider the walking wounded, obviously in these scenarios, we want to make sure there's a safe place for them to be held or waiting for care or potentially reunification. And so trying to identify that, or if this is like a school environment, possibly delegating teachers to trying to keep these children safe and monitoring them. If this is like, let's say, a fairgrounds or something where a bunch of families are together, it's best to keep children together, if possible, with their parents, as parents can alert you if there's changes and know their children best and can provide for them their basic needs that they need. This reunification piece is obviously a big one, and I would encourage you to ask the questions to your agencies or your hospital, what the plans are if this were to occur. As children spend a lot of time away from their parents during the day, whether it's through daycare or school, and so in a mass casualty incident, there's likely going to be a need to pair them back with their families, and we need to make sure we're doing this in a safe way and making sure the child's going back with a legal guardian. And the sooner we can do this, the better, as it will diminish the mental and physical effects of separation from their loved ones. And there are resources depending on this, the scope or the, largeness of the scenario that could be used. But also there are a lot of other, at the end of this talk, I do have some links that would be helpful to resources too. And so I think it's really important. During Katrina, it took up to 6 months to make um, some family reunifications happen, and that has to be extremely stressful. So something to look into. The other population we always need to consider is children with special healthcare needs, and probably 1 in 5 children have a healthcare special need, whether it's asthma, autism, or more complex medical care. And so, in these scenarios, you can look for potentially a bracelet or use caregivers to potentially provide that information. They might have a difficult time, or you might not know if they're in pain. So, again, attention to the vital signs. They may have a higher heart rate because they're in pain. And the triage algorithm still applies. So it's not that they have a different algorithm. You're still going to be using Jumpstart or SALT or whatever algorithm your agency has determined is best. So this is our last patient triage here. So it's a 16-year-old male. He's not able to walk. He's breathing 25 breaths per minute. He has pulses present. He's initially mute, and then he starts yelling that his legs hurt, and he keeps asking why this happened. And then a teacher who's on site says that he does have autism, and you note he has some bleeding of his left arm and a bruised and swollen left leg. All right, so a few red, a lot yellow, a couple green. All right, and no blacks. All right, let's walk through it quick. So when it comes to Jumpstart, not able to walk, they are breathing. And when we look at the respiratory rate, they are within the normal range. So then it really comes down to, do they have pulses and what is their mental status? So they are palpable pulses. And with the mentation, they are alert, they're verbalizing. So this would be delayed or yellow according to Jumpstart. And with SALT, They would be triage second. They are breathing. They seem to be having commands and purposeful movements. Pulses are present. They're not in distress, and there's no obvious hemorrhage control that we're aware of. So then it depends on what we think these injuries are, whether we would say green or yellow. I again went with yellow because of jumpstart, but again, I think as we can see, um, this could be interpreted differently depending on what this actually looked like. A couple last aspects about pediatric patients is they can change. As we know, they can compensate until they aren't. And so considering reevaluation, those green walking wounded could potentially have a change in their vital signs or how they're doing. Children can be over triaged. Again, a crying child is actually reassuring that they are probably perfusing and breathing well. So, again, we want to make sure we're getting resources to the ones who need it. And then trying to consider some comfort measures, whether that's utilizing a caregiver to try to help comfort so that you can get a better assessment of what's really going on with that pediatric patient, or trying to use something in your environment to try to help soothe or calm. Here are some of the resources I was talking about. Obviously, if you're pulling up my PowerPoint, they would be a more of a direct link. Otherwise, if you Google any of these groups, you will find a plethora of disaster management information, and I invite you to kind of explore those. My resources, and then just really, oh, oh my goodness, I don't know where the last screen went, but I had where is it? Oh, there we go. My summary slide. Okay. So in summary, obviously these algorithms are really designed to help us with resource utilization and making sure the most good goes to the greatest number. Pediatric patients' airways are different than adults, so reposition and allow for rescue breaths while assessing their triage level. There are some physiologic differences in pediatric patients that have been noted, airway being one, but also their chest wall can be more compliant. They have lower glycogen stores and are at risk for hypoglycemia. They can't measure, or they can't maintain their temperature the same, as well as their dependence to their family. And so or caregivers. And so keeping family units together is always important. You want to avoid, again, the exposure and hypoglycemia. Look for early signs of shock, which could be missed as it could be subtle, just such as, elevated heart rate or respiratory rate. And then consider reunification and think about how that might look on scene or within your agency or hospital. It's been a pleasure to be here with you guys tonight. Feel free to be on for questions, but I know everyone's probably tired. But I am happy to answer anything I can or provide information later.
Dr. DePompolo, thank you so much. We
Yeah.
don't really have time for questions, but I
Okay.
do want to remind everybody that we have gathered your questions and we will work at getting answers to them out to you as soon as we can. So don't worry if you asked a question and you didn't get an answer, we will work on it. Thank you so much. That was just
Thank you.
great information. And,
There was
it's
a
one of
lot
those
for
things.
everybody on all the talks. It was great tonight.
Well, the comparison of Jumpstart and Salt is compelling to me because people always ask, which one's better? Are you Team
Yeah.
Jumpstart or Team Salt? And it sounds to me like they have their uses, both of them.
Yeah, and it is real. I find it very interesting. And I think it was interesting just what the world uses too, that there's so much variation even out there. And so who knows, maybe in time we'll be using something different. So I think it's just always interesting. So yeah, I appreciate being here tonight, and I'll look if please feel free to reach out to me if there's more specific questions. I was trying to see if I could scan, but I'm not reading fast enough.
Yeah, there were a lot of interest. Thanks so much. And thanks
Yeah,
for your
thanks.
service to EMSC. We
Thank you.
appreciate that too. Those of us in EMSC appreciate that very much.
Absolutely.